Everyone, my name is Dowd. This is your Genomind webinar. Today we'll be talking specifically about pharmacokinetics, pharmacokinetic drug interactions, drug-drug and drug-gene interactions, and we'll be introducing everyone to GenMed Pro, which is our newest and greatest drug-gene interaction software. So you may be curious to know who's speaking to you tonight. My name is Dan Dowd. I'm a pharmacist by training, a PharmD. I'm currently the VP of Medical Affairs with Genomind. I've been with the company for about 6 years. I got my pharmacy degree way back in the day from Rutgers, and for 13 years following that, I taught pharmacology in New York. Also have a background in retail pharmacy management and clinical trainings. If you're interested in any of my publications, you can see the links there. We will be sending out this slide deck tomorrow for everyone to view. We are currently recording this presentation, so you'll have access to the recording. I would like to also go over some housekeeping type things. This is a Zoom webinar. You all are muted, but you will notice a Q&A function at the bottom of your screen somewhere. So if you have questions throughout the presentation, click that Q&A box, type in your question, and you don't see them right now, but we have members of the Genomind Medical Affairs team in the background answering these questions. So you'll be talking to a real live PharmD or PhD or MD to answer questions. With that in mind, we will also have a live Q&A at the end of this webinar, but if you have an urgent question, feel free to ask it throughout. This medical affairs team is fantastic, so I challenge you to stump them. Today, we're going to talk about our newest product called GenMed Pro, and this is the agenda for today's presentation. So we'll first do some pharmacokinetics 101. We won't go too deep into the weeds because this stuff can get rather confusing, but everyone needs to have a fundamental understanding of pharmacokinetics to understand not just pharmacogenetic interactions, but also how these drug-drug interactions can influence blood levels and side effects and outcomes to different medications. We will talk briefly about what GenMed Pro is and what it's intended to do and what problem it is intended to solve. But this is the type of product that is better, I'd rather show than tell. So we'll have a live demo of the product, and we'll do different drug scenarios to see how that looks under different scenarios. And then lastly, we'll have a live Q&A. So let's start off with pharmacokinetics 101, and we're going to take it way back to when I was in pharmacy school. The very first day of pharmacy school, they teach you about pharmacokinetics, and they teach you, it's drilled into your memory, the acronym ADME, ADME, and this is the core of what pharmacokinetics is. Pharmacokinetics, you can think of it as the life cycle of a drug. So any medication usually follows these 4 steps in the body. Not every one of these steps, but usually most drugs follow these steps. A drug has to be absorbed. So that's the first phase of pharmacokinetics, absorption. How do we get a capsule into the body? Most drugs have an absorption phase. The exception to that would be IV medications. So if I inject something directly, morphine, for example, directly into a vein, that bypasses the absorption phase. So most drugs, however, are oral medications, and anything oral requires an absorption phase. The reason that's important is because we all have genetic differences where we absorb drugs differently. Absorption can affect the exposure to a medication, another term you should be familiar with. Exposure is a measure of the blood levels of drugs over time. So after absorption, after a drug crosses one of these biological membranes, it then needs to get to the site of action. This is distribution. So how do we get a drug? Let's say we take an antacid. How do we get this antacid from this capsule across the membrane and then to the site of action, which is the stomach? And the blood is the most important distribution organ. It seems odd to call the blood an organ, but for our purposes, we'll call it an organ. And within that organ, there are multiple different proteins that help carry drugs throughout the body. Many drugs are not soluble in the blood, so there's these protein carriers to carry them around. So absorption and distribution. Once a drug gets to the site of action, your body, or more specifically, your liver, usually views a drug as a toxin. Okay, and what do we want to do with toxins? We want to remove them from our body. The first step in doing that is to metabolize the medication. Okay, not all drugs get metabolized, but the vast majority of them do. And once a drug is metabolized, it becomes more water soluble. So when we say metabolism, all we're really saying is let's make this drug more water soluble. Why do we want it more water soluble? Well, because it's easier to excrete it if it's more water soluble. If the liver is the most important drug metabolism organ, the kidneys are the most important drug excretion organ. Okay. And we'll show a couple of different phases of drug metabolism, phase 1, phase 2, but what they both have in common is that they make a drug more water soluble, so you can more easily excrete that medication. So these are the 4 phases, or the 4 parameters of pharmacokinetics. We will be focusing today on just 2 of these, which is absorption and metabolism, because we specifically look at genetic biomarkers that influence your drug absorption and your drug metabolism. And there is wide variability in how individuals metabolize drugs. Unfortunately, doses, our standard doses of medications, are based on population averages, but there's a whole lot of variability within those averages. So we'll start with drug absorption. A drug has to get into your body. We will predominantly be talking about psychoactive medications during this presentation. So we need to be concerned with not just how a drug gets into your body, how well it's absorbed across the intestines, but also how well it penetrates the brain. The brain is a bit of a unique organ because there's a layer of fat around the brain known as the blood-brain barrier. And if something doesn't penetrate the blood-brain barrier, well, then it's not psychoactive. And so most of the medications we prescribe on a daily basis cross the blood-brain barrier to varying degrees. Okay. I would consider the brain an important organ. I would consider my intestines an important organ. Most of the body's important organs are surrounded with these proteins called PGP, or P-glycoprotein. You'll notice the brain has PGP. You'll notice the liver has PGP. You'll notice the intestines, the testes, the kidneys. In pregnant women, the placenta is loaded with PGP. PGP is a little protein that prevents toxins from entering our most sensitive organs. I didn't actually state that correctly. What PGP actually does is takes toxins and spits them back out after they have crossed a biological membrane. So if you look at this image to your right here, the triangle is some type of drug or some type of toxin. Let's call it morphine for now. Morphine crosses a biological membrane. It could be the blood-brain barrier. And then PGP grabs that morphine and spits it back out. It prevents this from staying within the brain. If it was intestines, it would do the same thing. You would absorb a medication, PGP would grab it and spit it right back out. Morphine is an example. Escitalopram is an example. Aripiprazole is an example. Topiramate is an example. These are all medications that are sensitive to P-glycoprotein. And there is variability into how efficient these P-glycoproteins are. Some of us make nice, healthy, normal PGP. Some of us make deficient, wimpy, weakened PGP. And you can imagine if your PGP is deficient, you're getting more drug into the brain. You're getting greater penetration because that PGP isn't spitting it back out of the brain very efficiently. So we look at genes that affect drug absorption. Specifically, we look at a gene called ABCB1 that impacts how efficiently these PGP work. And those with a wimpy PGP tend to have higher blood levels of certain medications. We'll use paroxetine as an example. If your PGP is wimpy, paroxetine gets into the brain and it stays in the brain. The PGP doesn't kick it back out very efficiently in some individuals. Now, after absorption, like I said earlier, most drugs undergo some type of drug metabolism. Drug metabolism can occur in two different phases. You have phase 1, phase 2, but both of these phases are trying to accomplish the same thing. Make a drug more water soluble so you can urinate it out. Now, let's start with phase 1 because probably everyone on this webinar is familiar with something called CYP450, CYP450. These are liver enzymes that do most of the heavy lifting during phase 1 metabolism. There is more variability in CYP450s than any of these other drug metabolism enzymes. Tremendous variability, especially with 2D6, 2C19, 2C9. They have the biggest impact on blood levels. So, for example, if someone is deficient in CYP2D6, you can see blood levels that are 3, 4, 5, 6-fold higher than they would be in the normal person. Okay, that's phase 1 metabolism. All your CYP450 enzymes are phase 1. As you can see here, we use aspirin as an example. Here's aspirin. It gets metabolized into something more water soluble. And then some drugs will go through this phase 2 reaction, often called conjugation. And conjugation just involves adding a very big, bulky, more water soluble compound, chemical compound, to your drug. So here's aspirin. It goes through phase 1 metabolism, becomes more water soluble, goes through phase 2 metabolism, and now this big, bulky glucuronide has been attached to it. So that usually deactivates a drug and makes it more water soluble. Okay. I mentioned these two different phases because we will look at genes that affect both phase 1 and phase 2 metabolism. Okay. All of your CYP450s are phase 1. All of your UGTs are considered phase 2. Phase 1 usually has the biggest impact on drug levels, and there's also greater variability in phase 1 genes. Okay, here are the different pharmacokinetic genes that we look at on our panel. So our panel is known as GenPro Express, Genomind Professional PGX Express. We call it GenPro internally. There are 24 genes in total, but 9 of these genes are pharmacokinetic in nature. Okay, again, pharmacokinetic genes impact drug exposure, impacts drug levels of medications. And this is important because if you know somebody's expected exposure, you can do one of two things. You can pick an alternative medication, or you can dose adjust appropriately. So this is really personalized medication. And when we look at some of the guidelines later, you'll see those guidelines usually provide those two different alternatives. They'll say, use a different medication that doesn't go through this pathway, or just dose adjust for this individual. So what genes do we look at on our pharmacogenetic panel? Well, we look at 2 of these P-glycoprotein genes. Remember, they affect absorption. We look at 6 CYP450 genes. Here they are, 1A2, 2B6, 2C9, 2C19, 2D6, 3A4, and 5. And then we look at 2 of these phase 2 enzymes, UGT1A4 and UGT2B15. We'll talk about more of these. We'll talk about these in more detail. I mentioned the term exposure before. Okay, so be comfortable with that term exposure. We get a lot of questions about this. You know, what do you mean by exposure to a medication? Exposure is just a measure of concentration over time. You know, how much of this medication are you actually exposed to? How much of this medication is actually in your body? And what we use to determine exposure is a term called AUC, which is an acronym for area under curve. I imagine all of you have seen a time versus concentration curve before. So here's an example of some of them. At time 0, we mostly have concentrations of 0. And then most drugs have an absorptive phase where the drug concentration increases, and then a elimination phase where the drug concentration decreases. One exception to that would be an IV dose. IV doses have no absorption phase. And so you start off at peak concentration and everything is elimination after that. When we talk about area under the curve, we are literally talking about all of this area under the curve right here. It is a measurement of the volume beneath this curve, okay? The higher your area under the curve, the greater your exposure to a medication, okay? So if we look at the graph to the right here, you can see these exposures are drastically different. The blue one has a very high peak, but very short duration, whereas the red one has a shorter peak, but a longer duration. When we talk about exposure, we will show some graphs later on how changes in AUC are a measure of the severity of drug interactions. Okay, next, oh, that was too fast. So next slide is how do we compare these differences in drug exposures to different genotypes? Well, here are your 5 different phenotypes for CYP450 genetics, okay? If I were to measure anyone's CYP450 genes, your genetics would be one of 5 different flavors. You would be an extensive metabolizer, which is the same as normal, so that's an NM. You can be an intermediate metabolizer. You can be a poor metabolizer. They're listed up here. On the other end of the spectrum, you can be a rapid metabolizer or an ultra rapid metabolizer. Okay, so there's different degrees of slow metabolism, there's different degrees of fast metabolism, and then EM is Goldilocks. That's just normal. Okay, these 2 horizontal bars here, that's what's called your therapeutic window. The whole goal of medication is to maintain the concentration of that drug within the therapeutic window. Okay. If you're a normal metabolizer, that's pretty easy to do. You know, you give someone a standard dose and they are likely to stay within the therapeutic window. If you are a poor metabolizer, it's rather difficult to keep somebody in that therapeutic window. You can see PMs for most of the life of that drug, they are above the therapeutic window. On the other end of the spectrum, ultra rapid metabolizers are more likely to be below the therapeutic window or subtherapeutic. So the goal here is to know this information ahead of time and then dose adjust accordingly to try to maintain your patients in the therapeutic window. Here's a real-world example of what we just discussed there. This is a measurement of metoprolol blood levels. Metoprolol is the world's most common beta blocker, and these bars represent the AUC, okay, standardized for dose. Let's start with your normal metabolizer, your EM. Okay, you can see they have AUCs around 10. Intermediate metabolizers are significantly elevated. Poor metabolizers are the most elevated. And then ultra rapids are about have half the concentration of extensives. Any drug that's sensitive to a CYP450 usually follows this pattern right here. EMs are normal, IMs significantly higher, PMs can see really astronomically high blood levels in poor metabolizers. When we start to look at some of these guidelines, many of the guidelines say reduce your dose by at least 50% in poor metabolizers. Okay, so everything we've talked about up to this point has been drug-gene interactions, but we also need to take into account drug-drug interactions, because if we forget drug-drug interactions, we are missing probably 20 to 30% of important major interactions that can occur. Let's walk through this scenario on the screen here. Let's imagine you were giving somebody Adderall or an amphetamine or a lisdexamfetamine, whatever you prefer, something in the amphetamine family. All of the amphetamines are metabolized by CYP2D6 into an inactive metabolite. Okay, this is what normally happens up top. Now, let's imagine you gave someone Adderall, and at the same time, a different prescriber gave them fluoxetine or Prozac. Fluoxetine is one of the more potent 2D6 inhibitors out there. You notice the magnitude of 2D6 shrinks once fluoxetine is on board. So once you have less enzyme available, you cannot efficiently break down your Adderall. Your Adderall levels start to increase when fluoxetine is added to the drug regimen. This is at the heart of all CYP450 drug-drug interactions. So if you understand this concept here, you understand how all these different drug interactions work. It works the same for 2D6 as it does for 2C19, as it does for 1A2, as it does for 2C9 and 3A4. Inhibitors reduce the enzyme activity. Okay. Potent inhibitors, really strong inhibitors, can almost eliminate this enzyme activity completely. So taking a strong inhibitor is almost equivalent to being born a poor metabolizer. Okay, that's why it's important to account for not just the genotype, but also any other drugs that are interfering with this enzyme. Okay, you can be born a poor metabolizer, or Prozac can turn you into a poor metabolizer. Your body doesn't know the difference. All your body knows is it can't metabolize Adderall now. On the other side of the coin is enzyme induction. Okay, let's take vilazodone as an example. Vilazodone is sensitive to 3A4 metabolism. It gets broken down into an inactive metabolite. If you happen to take St. John's wort, an over-the-counter antidepressant, supposedly, St. John's wort will amplify the effects of 3A4. Well, how is that possible? It's an over-the-counter herbal product. They're safe, right? Well, St. John's wort has many, many significant drug interactions. And the reason it does that is because it is a potent enzyme inducer. It amplifies the effects of 3A4. And so because you have more enzyme around, now your vilazodone blood levels go down, 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 down. Okay, so enzyme inhibition versus enzyme induction. There are more enzyme inhibitors out there than there are enzyme inducers. Probably at least, fourfold more inhibitors than there are inducers. So drug-drug interactions via enzyme inhibition are more common. Here's some real-world examples of all of this. So here, going back to our area under the curves, our time versus concentration curves. Here's some medications. Don't worry too much about what the meds are, but this is an anticoagulant, which you see. We're looking at the top graph here, and we're looking at the triangles. Okay, this is an anticoagulant and a standard AUC. This is what most people would experience. Now, if you give this person a moderate inhibitor, in this case, it was, I believe it was ketoconazole, which is really more of a potent inhibitor. But in this case, if you give this person ketoconazole, you can see that the AUC of the anticoagulant is significantly increased. In fact, if you were to measure the volume here and measure the volume here, the difference is about twofold. So we would say that this drug-drug interaction causes a twofold increase in AUC. That's considered a moderate inhibitor. Use the same drug on the bottom graph here and add a minor inhibitor to it. In this case, I believe it was diltiazem. Okay, don't worry too much about the drugs, but the take-home message here is that this boosts your AUC by 1.4-fold. This would be considered a minor inhibitor. And these definitions come from the FDA. The FDA defines a minor inhibitor as anything that causes less than a twofold increase in AUC. Moderate inhibitors cause a 2 to 5-fold increase. Major inhibitors cause a 5-fold or greater increase. So can you imagine giving someone a medication and then giving them another medication and their blood levels of that drug increase 5-fold? Well, that's exactly what happens with Strattera when you give it with Wellbutrin. Here's an example of that right here. If you look at these squares, the white squares down here, that's atomoxetine. Atomoxetine by itself, standard doses of Strattera. Now, if you were to add on Wellbutrin or bupropion, bupropion is a major drug inhibitor. A major enzyme inhibitor. So it boosts the AUC 5-fold of atomoxetine. That's a dramatic increase, okay? And you can imagine that a patient would experience significantly more side effects to atomoxetine if you suddenly raise their blood levels by 5-fold, okay? So hopefully I'm impressing upon everyone the importance of these drug-drug interactions. Most of them are minor, some are moderate, few are major, but at least 10% of the time, we ran through our database and we found that at least 10% of the time, people are on drug regimens with at least one major drug-drug interaction. Now, if we look at inducers, it's just the opposite. So in this case, we're looking at medication for HIV. Don't worry about what the medication is, but with this medication by itself, we get the AUC curve with the black dots right here. And then when you add an enzyme inducer, you see the AUC with the triangles. So there's a significant decrease in blood levels with a moderate or major inducer. Okay, let's complicate things a little further. What if you gave somebody 2 inhibitors? Well, intuitively, you expect a stepped increase in AUC, and that's generally what you see. So here we have some HIV medications and a medication used for fungal infections. If you give this medication by itself, you have the triangles, the AUC down here with all the triangles. If you add one inhibitor to the mix, you see an elevation in AUC. If you add 2 inhibitors to the mix, you see a dramatically increased elevation in AUC. So these inhibition properties are additive. If you add multiple inhibitors, you can see stepwise increases and increases in AUC. And then last but not least, we know that your genetics, together with drug-drug interactions, can change your blood levels also. So here's 2 images of omeprazole, which is Prilosec, an over-the-counter antacid. So here's Prilosec in extensive metabolizers with an inhibitor. There's not much of a difference in the AUC. Now, what if you did that in a poor metabolizer? If we give omeprazole to a poor metabolizer, we see elevated blood levels. It's exactly what we expect. But if we give omeprazole to a poor metabolizer that's also taking ketoconazole, we see even more dramatic increases in blood levels. So it's not just drug-gene interactions. It's not just drug-drug interactions. It is everything. All of these parameters interact with each other and can cause significant changes in blood levels. Okay, how do we compare these genotypes and phenotypes to inhibitors and inducers? Well, we generally treat extensive metabolizers the same as if there was no other inhibitor or inducer on board. We generally treat intermediate metabolizers as if we would a moderate inhibitor. And generally, a poor metabolizer is equivalent to having a strong inhibitor on board. So if I give you Strattera or atomoxetine, your blood levels as a poor metabolizer are likely to be similar as your blood levels with a strong inhibitor. Okay, so these are rough equivalencies between inhibition strength and genetic phenotype. This concept that we're talking about back here is the concept of phenoconversion, okay? And that's really at the heart of this talk and the grand rounds that we do next week. Phenoconversion, I'm going to read the definition here. Phenoconversion is the mismatch between somebody's genotype-based prediction of drug metabolism versus their true ability to metabolize drugs. So if I looked at your genes alone, I may get a report back that says you're a normal metabolizer. And I may say to myself, well, this person's normal. I can give them standard doses of drugs. But if I haven't also looked at the other medications they're on, I'm missing about 20 to 30% of significant interactions. Okay, that's this concept of phenoconversion. If you just look at the genes, you're missing something because other drugs can phenoconvert you. They can turn your genetically normal phenotype into something that's not normal. This was considered a black eye for pharmacogenetics. In fact, there was a publication about 4 or 5 years back calling phenoconversion the Achilles heel of pharmacogenetics because we were missing so many of these phenoconverted patients, like 20 to 30% of them. So we saw this as a problem, and it's one of the reasons we built the software that we will show you shortly. Okay, so here's, we'll just do this top example of phenoconversion here. So if someone happens to be born a normal metabolizer at 2D6, I look at their report, they're genetically normal. I say, great, let's give them Strattera, I'll give them normal doses. What I didn't know is that they were also on Prozac, and Prozac phenoconverts them to a genetically poor metabolizer. Okay, so what we expect to see is this green area under the curve based on their genetics. What we actually see is this red area under the curve based on their phenoconversion. Okay. Okay, hopefully everyone is thoroughly confused except for the pharmacists on the call right now. So we recognize, and I recognize that this is complicated. And truth be told, one of the reasons we built this software, 3 or 4 years back, was to help us manage all of these different drug-drug and drug-gene interactions. But we liked it so much, we thought our providers could use it also. And so that was sort of the impetus behind building GenMed Pro and its predecessor, which was known as GDIG. Okay. The take-home message here is we need better tools to account for these complicated interactions. And we think we built one. I'm going to go quickly through this slide. I want to talk about some statistics that are out there. These come from different sources. Some of them come from Kaiser. Some of them come from NIH. Some of them come from various journals that are out there. But about 20% of outpatients 40 to 79 years of age will receive polypharmacy. Okay, these are 2016 numbers, but that number probably still applies. At least 20% are on multiple medications. The risk for significant interactions are 50% if you're on 4 or more drugs, and 100% if you're on 10 or more drugs. 10 or more drugs may sound ludicrous, but there are quite a few people, especially in the Medicare population, that are on greater than 10 medications. Over the next decade, it's estimated that polypharmacy will lead to over 4.5 million hospitalizations and 150 deaths. Psych medications, so psychoactive substances, is the third most expensive class of medications for Medicare recipients. Adverse drug events total 1/3 of all hospital adverse events, and at least 24 to 33% of patients post-discharge had adverse drug events that were deemed preventable. Okay, so this is serious, this is real, and we need better tools to manage it. That brings us to the tool that we built and enhanced over the last couple of weeks, which is known as GenMed Pro. Okay, what is it? Again, I'm going to briefly tell you what it is, and then I'd rather show than tell. It is precision drug-gene interaction software. Okay, it marries your drug-drug interactions to your drug-gene interactions to demystify some of these complicated interactions. It provides a composite score of all interactions in a patient's profile. What I mean by that is if you've used a drug interaction checker in a past, you probably notice that it breaks interactions out into pairs. Even if you enter 6 drugs into a profile, it will say A interacts with B and A interacts with C, but it doesn't tell you how everything interacts with everything. Our tool does that. It gives you a composite score. So if you remove one drug, it will change the outcomes for all of the drugs. We talked about phenoconversion. This tool addresses the blind spot of phenoconversion within pharmacogenetic reports, because this tool comes with every report. Every pharmacogenetic report you get gives you access to this software. It accounts for multiple different pathways. We know that many drugs are metabolized by multiple different CYP450 enzymes. We account for that and rank the strength of each one of these pathways. And it also accounts for drug duplications. So if for some reason somebody's on 2 benzodiazepines, this will flag that. And we've been talking a lot about psych medications so far, but this tool includes non-psych medications also. We know that our customers don't exist in a vacuum. Our same depressed patients have high blood pressure and other conditions. So we need to know how all of these drugs interact with one another. Now, the predecessor to GenMed Pro was GDIG, or the Genomind Drug Interaction Guide. Just this week, just Monday, we rebranded it, relaunched it with a bunch of new features. So I want to address these new features. We have incorporated pharmacogenetic guidelines into the tool. What does that mean? Well, you may be surprised to know that there's almost 300 medications where the FDA has pharmacogenetic guidance in the label. We've incorporated that guidance into this tool. There are 2 groups of researchers in the world who provide pharmacogenetic guidelines. We've incorporated those guidelines, and these will all be patient specific. Some of the feedback we received from our precursor to this was that, how do I know what medications, how similar medications would react in this patient's drug profile? So we built an alternative drug option. You have the ability to evaluate multiple med categories and classes. And last but not least, we've incorporated 4 new genes into this tool. PGP, P-glycoprotein related genes. So those are related to drug absorption. Phase 2 enzymes, UGT1A4 and UGT2B15. And then 2 genes which aren't pharmacokinetic but are important. These genes are called HLA-A, 3101, and HLA-B, 1502. And these have to do with how sensitive you may be to Stevens-Johnson syndrome with carbamazepine or lamotrigine or oxcarbazepine. Okay. I mentioned the guidelines that we've incorporated into this tool. Those guidelines come from one of 3 sources: the FDA, CPIC, which is the Clinical Pharmacogenetic Implementation Consortium. It's a global group of researchers that publish peer-reviewed guidelines. They have, I think, about 24 published guidelines to date. And then DPWG, who also publishes peer-reviewed dosing guidelines, pharmacogenetic guidelines out of Europe. So now is a time where we will switch gears. I'll show you what this tool looks like. I'll do a live demo. I'll put some common medications in there. And then we'll do some Q&A and see if everything makes sense to everyone. So I am going to stop sharing here for a second. And I think I timed out, so let me reload this program. Okay, so this is it. This is GenMed Pro right here. Okay, this is a demo account here. So this looks a little different than what you would see. The only difference, however, is that I have to pre-populate the genetic profile. Okay, you would never have to do that. Your genetic profile would already be fully populated. But since this is a demo account, I need the ability to change different genetics here. So if you logged in to your portal, to the Genomind portal, you would land on this GenMed Pro page, and your genetic profile would be pre-populated, your patient-specific genetic profile. If you hover over each one of these phenotypes, it gives you a brief definition of it: poor metabolizer, intermediate metabolizer, the rest are all normal activity. So this is a person who has a non-functional 2D6 enzyme, who's HLA-B positive, means they have a higher risk of skin reactions with certain medications, and they have this UGT gene, which affects some of the benzodiazepines. Put a pin in CYP1A2 for now. We'll come back to that in a moment. Your genetic profile will be pre-populated. A legend down here will describe the different icons that we use, but let's show you the icons first. And then we can go back to that legend. So you would populate this like you would any other drug-drug interaction checker. I'm going to start here with Abilify and also some Ativan, and maybe we're considering some Lamictal as well. Okay, let's start with the Abilify. First thing you see is this arrow right here, and the arrow is a prediction of exposure. Do we expect higher, lower, or standard blood levels for this person? Well, this person, we expect higher blood levels, okay? The icons that you see here stratify this into high, moderate, or low risk. So high risk options, you might want to consider an alternative here. You can see blood levels that are dramatically higher when you see this high risk icon. Moderate risk is a caution and monitor. Low risk means it's probably not going to be clinically significant except for drugs with a very narrow therapeutic range. So in this case, we expect higher blood levels. This is a high risk interaction, and we know it's caused by the person's 2D6 poor metabolizer status. So this is a red flag. I'm automatically concerned here. Now, what do I do about it? Well, one thing I can do is click the PGX Guidance tab that you see right here, and that will highlight any guidelines that are available for that medication specific for this individual's genotype. So if I scroll down here, I see that the FDA label has some guidance. It says in 2D6 poor metabolizers, administer 50% of your usual dose. Well, that's rather specific, and that's some pretty good guidance there. If I were to look at the DPWG guideline, its guidance is similar, not entirely the same as the FDA, but it says no more than 10 milligrams per day and 67 to 75% of your maximum dose, your maximum standard dose. And so two different agencies telling you to decrease the dose of aripiprazole, even though the exact amount is slightly different, the take-home message here is we expect higher blood levels of Abilify. We should consider cutting our dose 25 to 50% in this individual. Okay. You'll also notice that all of these links are live. So these links bring you right to the FDA label. I know that print is rather small, but these links are live, and this will bring you right to the DPWG guidelines. Okay, so if you don't believe us, you can see the actual source where this information comes from. There happens to be no CPIC guideline for this drug-gene interaction, but CPIC is currently working on an antipsychotic guideline, so stay tuned. Okay, so that tells me what to do with Abilify in this situation. What if I said, well, I'm just not comfortable with this risk? What are some alternative meds to consider that might have a lower risk? I click the alternative medications button, and this lists other second generation antipsychotics, and it lists them in order of low risk to high risk. So maybe I was considering Rexulti for this individual. I see here now that brexpiprazole has the same high risk interaction that Abilify does. So does iloperidone, so does risperidone. I might want to consider perhaps quetiapine, perhaps cariprazine, lumateperone if clinically indicated, because from a genetic standpoint, these all have a lower interaction risk. So I think I'll go with lorazepam here. I'll replace it. And now I have cleaned up what was previously a significant gene-drug interaction. Okay. Let's move on to Ativan or lorazepam here. So here's Ativan. This is a moderate interaction. We expect a moderate increase in blood levels, and that is due to this person's genotype. Okay. If I wanted to add, let's get rid of Lamictal for a moment and add Depakote, valproic acid. Okay. Before I add this, keep an eye on this icon right here. Right now it's moderate. I add Depakote, and that immediately becomes a high-risk interaction. Well, what changed? The person's genetics hasn't changed. What's changed is that we've added a drug-drug interaction on top of a drug-gene interaction. So if I get rid of Depakote, moderate. If I add Depakote, major. You can always look at the interaction details to get more information. You click this tab and it identifies what we call perpetrators. It identifies all the perpetrators that are impacting Ativan. So what we see here is that as far as drug-drug interactions go, Depakote is a moderate inhibitor of this enzyme. What complicates it is that this person also has a drug-gene interaction, and they have a intermediate UGT2B15 enzyme. So this person was born with a deficient enzyme, and then we have further inhibited that deficient enzyme by adding the Depakote on board. So maybe we get rid of the Depakote and we consider lamotrigine or Lamictal. Well, we've added the Lamictal and we get a red flag. Uh-oh, caution, possible higher risk of drug-induced skin reactions. Now, this is not a pharmacokinetic interaction, but this is related to the HLA-B genotype. Having this genotype increases your risk of Stevens-Johnson by about 2.5 to 3-fold. So I probably wouldn't be all that comfortable with Lamictal. If we look at some alternatives here, keep in mind Lamictal is used for bipolar, but it's also an anticonvulsant. So you can filter by multiple different categories. And then again, you can filter by multiple different subclasses. Okay, so right now, I filtered by antipsychotics. I could get rid of the antipsychotics and filter by mood stabilizers, which I did right here. Maybe we'll replace it with lithium and see how we do. And then maybe I'll replace the Ativan with alprazolam. So we have just turned a fairly complicated and risky drug regimen into a much cleaner drug regimen because there's less interference. We can expect more standard exposure to these medications compared to our original medication list. Okay. I'm going to reset these medications and I'm going to add Zyprexa into the list here. Okay. Zyprexa with this cluster of genes looks pretty clean. No major interactions. We get the thumbs up right here. But many of you are probably aware that smoking status can interfere with olanzapine blood levels. So if we were to click this smoking button right here, you see that changes your output. Now we expect lower blood levels of olanzapine. And this is actually a pretty significant interaction. We would call it moderate. You can see blood levels of olanzapine drop by 50% in smokers who have this particular genotype. Okay. So remember when I said to hold off on CYP1A2 before, I asked you to hold off because CYP1A2 is a bit of an unusual gene. Some of us have a genotype that sensitizes us to cigarette smoke, okay? So if I get rid of the smoking, people with this CYP1A2 genotype are normal metabolizers, but they are sensitive to the induction of this enzyme. So if I add some smoking on board, that drops blood levels. If I add coffee on board, and when I say that, I mean greater than 3 cups of coffee a day, that can lower Zyprexa levels also. If I add an enzyme, a medication on board that is an enzyme inducer like Tegretol, well, that will lower Zyprexa levels significantly, okay? So your genes matter, your drugs matter, and this tool is designed to marry all of these different concepts together. Okay, so I'm going to switch back and we're going to finish up the a couple of slides, and then we can always come back to this tool here if people have questions during the Q&A. Okay, so welcome back. We're now in our Q&A section of the presentation. So it's been a pretty quiet crowd throughout the presentation. So feel free to enter questions in the Q&A box and we'll do our best to answer them. If you want an additional demonstration, we can pull up the tool and do that also. So ask your questions in the Q&A box. Okay, still a pretty quiet crowd here. At the bottom of your screen, you'll see a Q&A box. You have 3 pharmacists here ready to answer your questions. If there are no questions, that's fine. We'll wrap things right up, but we'll hang tight here to see if there's any questions. Okay, not a lot of takers, so I guess we'll just wrap things up. If you do decide you have questions, feel free to send an email to medicalaffairs@genomind.com, and we'll try to get you a response as quickly as possible. This, everyone who has joined will receive an email tomorrow with a copy of this presentation. And oh, actually, it looks like we do have a few questions. So let's see what we have. Cost of the tests and insurance coverage. Well, that always comes up. So when it comes to cost, the first thing I'll mention is Medicare and Medicaid. So Medicare has a coverage policy, a recent local coverage determination. Certain criteria have to be met in order for a patient to be eligible for Medicare. As a prescriber, you have to be considering, or the patient already has to be on a drug that has a CPIC or FDA drug gene interaction. And if that is the case, it will be covered under Medicare. When it comes to Medicaid, that's largely going to be state by state. And then when it comes to commercial insurance, most patients are paying $399 out of pocket. And that's the status for coverage. So how do we get the patient's genotype to match with the medications? I hope that question is, how do we change a person's genes? But that's what it sounds like. So I don't have a good answer for that one. Where is the CPIC drug gene interaction list? Great question. You can go to CPIC, I think it's called cpicpgx.org, or just Google CPIC. You'll find a section on their website called drug gene pairs, and that lists every CPIC drug gene pair and also ranks them by level of evidence, level A and B being the highest levels of evidence. Toriosima, can you grab that website from CPIC and respond to Thomas Reardon? Thanks, Tori.
Will do.
Thank you. Okay, now a question about how to select medications for effectiveness for an individual's depression. For example, what to pick first. Well, we didn't talk too much about pharmacodynamic genes on this presentation. This was all about pharmacokinetic genes. But there are some pharmacodynamic genes that are related to response rates, remission rates, or side effect rates. And so, for example, there's a gene called SLC6A4, which has been associated with increased side effects to SSRIs, or in some cases, lower response or remission rates to SSRIs. So coupling this pharmacokinetic data with this pharmacodynamic data can help with not only drug selection, but also drug. Another question about methylphenidate, any genes for methylphenidate, in particular CES. So CES, there is a pharmacogene for methylphenidate. It is called CES1. It's extremely rare to have a genetic variant in CES1. I think it's less than 1%. So yes, there is a pharmacogene related to it. It's not currently on our panel. We decided not to add it because it's such a rare gene.
Dr. Dowd, I'll let you know if any other questions come through, but it looks like we just cleared up the list of questions here.
All right, well, thanks, crew. I appreciate it. Yeah, looks like we're all good here. So again, if you have any follow-up questions, you can email medicalaffairs@genomind.com. And that concludes the presentation. So have a good night.